Next on the agenda is a derived, I guess, double act to talk about the patient portal. First up is Chris Calvert, who's relatively recently started as a consultant gastroenterologist in Exeter, but did his thesis really around the development and work of the portal. So thanks very much, Chris.
Thank you very much for inviting me to speak today. So I'm going to talk about IBD patient portals and is this the way forward? So just to set the agenda, we're in the midst of an information revolution at the moment. This has been going on for the last 40 years, and dramatically, times are changing to the point now where digital technologies are the part of pretty much everyone's lives here in the UK. And we've had three revolutions: the agricultural revolution, the industrial revolution, and now we're sort of going towards this point of the information revolution. And they're becoming fully integrated now. Most people do their shopping online, their banking online, the media has changed dramatically. People are booking their holidays online and sorting that out. But the NHS is a little bit behind in terms of the other service industries about how we're doing. And there's been a painful adoption of IT technologies within the NHS, and there's been different approaches made for that. So just to set where we're at the moment, last year 84% of households had internet access, 74% used online services. Currently, primary care is far better than secondary care. 15% of patients are now booking their clinic appointments with their GP if they can actually see them of the time, and 68% of people are using mobile devices to access the internet at the moment. So there's a huge market out there that we're missing. So back in, I think it was 2011, I was a little bit fed up in clinic of patients not having access to their blood tests really when they were on azathioprine, and phoning up lots to find out what the results were, and I felt this was not an ideal model of care. They didn't have access to the letters. So approached a few people to look at different ways of how we could enable patients to have access really to their bloods and clinic letters, and we used the renal teams have been far ahead of the game in terms of IT in the NHS, and used a model that they have developed to allow patients access to their records really. And what we wanted to do is allow patients access to their bloods, their clinic letters, the ability to monitor their disease and securely email the service, and then to have access to trusted health information. We wanted this app to be secure, easy and appealing to use, to provide accurate and trusted health information, and to be able to be integrated easily into routine practice, because if it's not easily usable by both the healthcare professionals and the patients, it won't be used. So if anyone does decide to embark on an IT project within the NHS, there are considerable barriers that you face, and I've not gone grey yet, but I think it will happen soon. They're generally split into three areas. It's technical, human, and organisational. And basically, this is how you end up feeling after a while. I was fortunate in Salford that they do have excellent IT support there, and they did enable the project to move forward at a pace. So what are the benefits of patients having access to the records? Now, in America, I think with it being a different provider system, most hospitals now provide access to their patients' record. The patients have access to their records, and they have to keep them themselves as personal health records. And there have been many studies done looking at the benefits of this. So they're thought to definitely improve communication, enhance patient empowerment and experience, and enhance safety. So this does seem like this is the way that we're travelling. So it took a year to develop the IBD portal system that we developed from the renal system at the time, and then we did a careful assessment of it and the effects on patients and their use. So once it was developed, we did an observational study. We recruited 183 patients, 75% of patients that were approached with inflammatory bowel disease in the clinic registered to use the service. And this was over a period of 6 months. Patients used an average mean login of 11.2 times with a median of 3, so there's some heavy users out there. and there's people that don't use it at all. So roughly about a quarter of people used it, never used it or used it once, and a quarter of people used it over 10 times in 6 months. And there's some people in between. It's very similar to the renal data that they have. On average, patients used, each login was over 5 minutes. So you're seeing that you're having a lot of interaction with patients through the portal, and you know, that is clearly, hopefully, going to be beneficial over time. There's a high level of user satisfaction. Over 98% of patients were either satisfied or very satisfied with the new complementary service. 90% perceived it supported their management. 32% said it helped with actual decision making. Interestingly, a third of patients shared their access of their records and bloods with their families and friends. Use was associated with disease activity, which is probably quite obvious. And in terms of health utilization, it wasn't powered, the study, to look particularly at that, but there was actually an increased use of the helpline for that. There wasn't any change in outpatient appointments. So whether it actually makes the service more efficient or not, I think is still debatable, and that's the same case for other other portal studies. It's clear that this is the direction of travel, as was mentioned before by David. The 5-year forward plan for the NHS does point that this is the way that we're going. Patients want more access to their records, want greater involvement in their care. We need to organise care better. It's clear that data's here, and we need to be able to capture it, and the best place to capture the data is actually from the patient and not what we record, probably, because that's probably the most accurate reflection. And there's technologies out there, and it's easily possible for patients to be able to have access to their records. And this is, I think, going to be introduced in the next 3 years. As part of the 5-year plan, it does say that every patient will have full access to the records and will be able to write in them. That's probably quite ambitious by 2018, but it will happen, and it is happening. So the conclusions of my talk are that we need to embrace technology and look at new ways of delivering care. Design and implementation within the NHS is entirely feasible. You do have to carefully consider the barriers, which are usually the IT department. And then the last question really is, do patient portals actually change clinical outcomes? I think they'll definitely change the patient experience, and patients really benefit from it in that aspect, but whether it actually change hard healthcare outcomes is still debatable, and obviously specific to the different systems that are developed.
Next up is Cath Stansfield, who's an advanced nurse practitioner in gastroenterology in Salford. She's fulfilled many national roles, including the chair of the RCN IBD Nurses Network and the UK NECO representative. I read with interest that you were voted IBD Nurse of the Year, which I was most impressed with, but you're also going to talk to us about the work on the portal. Thanks.
Thanks. I'd like to thank for being invited to talk today. Part of my brief was to give you a bit more of a practical introduction to patient portals and kind of my experience of using a portal at Salford. So when Chris came to us and discussed the use of a portal at Salford with us, it kind of once again reflected upon the challenges that we faced at Salford on a daily basis. So as with everybody else, we've got financial restraints, increasing demands on clinic capacity in outpatients, increasing numbers of unhappy patients with, more willing to articulate the dissatisfaction with services as well. We've got more complex therapies, and as we've heard over the last couple of days, personalised medicine, trough levels, metabolites, increasingly putting demand on specialist nursing services. And then, as discussed also this morning, the National IBD audit, the National IBD standards and the biologic audit have all placed considerable pressures on specialist nursing services in our attempts to kind of provide quality services to patients. But somehow, our managers, the trusts that we work for, expect us to work smarter and harder in our current environment. So anyway, we kind of reflected upon the use of the patient portal. Where in work, we have an embedded culture of running self-management. It seemed to fit well, but there were a number of hurdles that we needed to address. So what we know about patients, and the IBD portal was developed with a group of patients, and this is what they told us that they wanted, and also similar studies that surveys have demonstrated that patients want accurate and reliable information, they want improved access to information, and they want to be involved in decisions about their health care. But they also want us to talk to each other, so primary, secondary care integration, and actually the patient at the centre of the care, so they're the expert in care to move things forward. So was a portal the way forward? So for us, we've just got just under 700 patients on the portal at Salford, and it has really transformed the way that we manage patients. I think there's still a lot of work to do around the consultation with the patient, and that the portal becomes embedded within that consultation and drives the discussion for patients. But really it's enabled us to develop management plans for patients. So a patient will enter the symptoms, and if they seem to be tripping up with increased disease activity, then they get access to an instant plan of care. They're also able to monitor, and I think one of the biggest things that we spend time doing is discussing increasing trends of disease activity with patients, getting them to reflect upon when they had a flare previously, what were the signs and symptoms, and trying to get them to provide interventions much sooner rather than leaving it until they've got a full-blown flare. But I think the other thing, and the newer version of Patient View that's just about to come live, is that the patients are able to message us, but we're also able to message patients. So this is invaluable for patients on azathioprine monitoring, because we're actually just able to send a quick message to say that your bloods are okay, rather than a 20-minute conversation where we'd normally just ring somebody to tell them that their bloods are okay, and have that in-depth conversation about anything and everything. And it has really saved us some time. So I think the first thing that I reflected upon when I started to use the portal was patients' knowledge of the condition. And quite often I'll fill the data in for this screen with the patients sat in clinic. And it's amazing the number of patients 20, 30 years into diagnosis who don't know about the disease extent location. And I think this is why portals and imparting information so that patients are empowered to understand the implications of the diagnosis. So with regards to the condition, this page is bespoke for every patient. There's two different types. There's one for colitis and one for Crohn's disease. And it's tailored on disease extent and severity. We have a symptom checker. So this enables us to trend it over a period of time. And along the top here, there will also be a PROM and a fatigue assessment scale as well. Because I think most of us are conscious in clinic that we'd like to ask these questions or assess them, but within the timeframes that we've got in clinic, we don't actually enter the discussions about these problems that we have. And I think it's also good to go back with the patients and look at, when they were in green, what were you doing differently then? Were you taking your tablets? Was there less stress at home? And can we recapture that environment that we were managing them in at that time? I think the most important thing has been for patients to get good information about the disease activity, about the disease and diagnosis. So I'm very conscious when I do azathioprine counselling with a patient that we spend 20 minutes terrifying them to death about azathioprine and the importance of blood monitoring. And actually most patients will only take probably 2 key messages about that session away with them. So I think it's been really important that we can direct them back to the portal to take away more information so they can reflect on what we're telling them in clinic. Also, there is the functionality within the portal for us to undertake questionnaires and research. So when patients are consented to go on the portal, we also consent them to undertake research. And this is really easy because we can build in online surveys, so patient satisfaction surveys, patient experience trackers, those kind of things. But also, as we roll it out, we hope that we can build some national surveys about patients' experiences of living with inflammatory bowel disease. So what has the benefits to the service been? Really, the IBD portal has become a tool of self-management, and probably for the majority of people, it works really well. There are some people that the minority have access to the internet, don't have access to the internet, and we do struggle with some ethnic minorities also to engage them to use the portal. But as with the paper-based self-management approach that we use, we have seen a reduction in outpatient attendances of approximately 30%, and it's also helped with a reduction in DNA rates, particularly in the specialist nurse clinic, where the quiescent clinics with the patients with stable colitis, we were seeing DNA rates of above 30%, and they've now reduced down to approximately 15%. For me, I've now got a third person who checks the blood results in the equation. So the patients will ring me if they've noticed that the fecal calprotectin is increasing, CRP's up, just to make sure that I know that I've seen it. So for me, that gives me an assurance that things are being monitored. I think the other thing, and I've probably used increasingly recently, is tracking disease activity. We know that patients underreport the disease activity, and particularly for biologic requests, this has been really useful. So if we've got somebody who's borderline for meeting NICE criteria, we'd send them away for a couple of weeks to monitor the disease activity, and then we can use this information in the portal. So the barriers to implementation. Locally, nurse-led clinic, the portal has took off phenomenally. We've really struggled with patients that are seen in consultant clinic, but we've been fortunate with our local CCG to support some nurse time for us to roll out the self-management access, but also means that a nurse is now running alongside each consultant clinic. My IT knowledge was appalling. I can get round a colon, but to get round the NHS IT system, I struggled a little more. And also, I think within IT departments, the management and the key people change so quickly that I'd just persuade one person to do a bit of work and then they'd leave and go somewhere else. So it is quite a fast-paced environment that you have to learn to grapple with. So we do plan to roll out the patient portal. I'm leading a continuation study to roll out the portal to 4 centres throughout the UK, but we have got probably up to 10 centres that are showing interest in using the IBD portal. The main barrier within this project that we're seeing is clinicians' concerns about the impact of sharing information with patients. But really, from Salford's experience, there is no patient that's fearful of the information that they've received. Patients shouldn't be put on a portal without being educated and supported about the knowledge that they're about to receive. So we looked at patient feedback, and these are some of the quite common themes that we've seen. So quite often patients went to Google before they came to the clinic. So if I was putting somebody on azathioprine, they'd look at Google and get some horror stories, and it'd take me twice as long to persuade them to take it. So using the information that we've got on the portal, the patients are getting access to good information. But these are some of the feedbacks that we've had from the patients. So the future plans for the project, we aim to roll out the service to all patients at Salford Royal. And we're also in the initial stages of identifying and discussing with early adopting hospitals. The benefit of the portal using the renal patient view system is that there are 88 hospitals already in the UK that use renal patient view. And this means that the IT infrastructure has already been discussed and established for renal patients, and we hope that it's easy to move it across to inflammatory bowel disease. We're also going to look at the drivers and barriers to implementation and try and develop a roadmap to facilitate its national rollout. I think the other important thing as a nurse I was really keen is that I was only putting one lot of data in. One lot to the portal and one lot to the registry. So we've established the mandatory data sets as the key themes for the IBD portal. So this would mean that for in my centre, that as I put a patient on the portal, that the information is also going to be uploaded into the registry. Thank you.
Thanks very much, Catherine.